So while Jasmine switches the presentations, it's nice to be back. I suggested Bob go first, not because he's as good act to follow, because he's actually funnier than I am, but because what I want to show you is that we live in a global village, and global health includes local health. And we can learn from the experiments that happen in other places, and we should be open to that. And I'm going to show you how some of the things that we're trying to accomplish in Austin actually steal shamelessly from the things that I learned while being involved in AMPATH. And I want to apologize for the fact that I'm now at the University of Texas, and that burnt orange color is just plain ugly. All right, and you will never see me doing this. All right, so I don't have any disclosures, and we talk about population health, but I bet you if we went around the room, everybody would have a different definition of it. Bob gave one, but there actually are a number of appropriate ways of defining population health. One is that as a healthcare provider, I have the patients that I care for. That's my population, all right? And I think about what I can do to improve their lot in life. But then there's a hospital's perspective, and that's, whoever comes in the front door, the back door, whatever, that's their responsibility. And that's our population. They count them, and they can identify them, and they can do things to improve their care. Then there's a health system, which, if it's integrated, it's got inpatient, outpatient, et cetera. And they have a different notion of what their population is, and will do what they can to improve them. A payer's perspective is pretty easy. If they're sending you a premium, they're part of my population, right? But then there's, from a community perspective, it's everybody who lives here. And some of those people are not patients. And even when they are patients, there are things that affect the healthcare that are outside this different system. And so when I went to Austin, my charge was to create a Department of Population Health. And the medical school, since it was created by the taxpayers of Travis County, Texas. Travis County surrounds the capital of Texas the way Marion County surrounds Indianapolis, and they're both about the same size and both isolated in the middle of an agricultural community. That the medical school had as its mission to make Austin and Travis County a model healthy community. And so population health is core to its mission. Then I go there and create a department in a specialty that I know nothing about. There is no degree. I didn't have a degree in population health. I hadn't practiced population health. I'd done everything within inside a healthcare system. So I had to build a department, and I won't go into it. I did some crowdsourcing with a number of people, and they said, these are the things you got to focus on. And I developed a department with 6 divisions. One with community engagement and health equity, led by a faculty from the nursing school, who's running actually my largest division is being run by somebody who doesn't even have an appointment in my school. Our medical school combines all the primary care specialties into a single division that bridges my department, the Department of Medicine, and is run by a general internist and health services researcher. And then there's the Department of Occupational and Environmental Medicine. But then you can't do this without information, so the information sciences capability within the medical school is housed within my department, although it serves the entire medical school. And it's essentially Regenstrief. I mean, it's the stuff that you all have done all these years is in there, both data management and data analysis in the same group. Then we've got education and training. We've got a 2-year primary care clerkship that the medical students do that I'm not going to go into, and we've got a family medicine residency. And then global health. We stole Tim Mercer from Kenya and IU to be our director of global health. We'll go to that in a second. And then I've got a community strategy team that that is a group of 9 community leaders that we can bounce ideas off of, but they can also dope slap us and say, these are the things that you need to be paying attention to. And I actually have, because we can't do this in isolation, we're a small brand new medical school, that I have a person who's responsible for maintaining relationships with community organizations and community government, et cetera. This is how fast we've grown. So 3 years ago, my department was 2 faculty and 3 staff. We now have 220 people. We're going to have 250 by the summer. In the next 18 months, we're going to double in size because we're just now starting to write grant proposals. I've gone to a lot of recruitment dinners, I can tell you. And this is what we decided would be our mission. So our mission is to enhance the health and well-being of the residents of Austin, Travis County, and look at this guy out here, Central Texas, with emphasis on vulnerable persons and those suffering from health inequities. And I'll tell you why we did that. This is Texas, and Austin's in the middle there in the 5 counties of Central Texas, an area about 2.2 million people, which is about the same size as the Indianapolis Carmel MSA, right? This is the Austin Round Rock MSA. and it's rapidly growing. So that gives you an idea of the growth in size from 1970. It's essentially tripled in size from 1970 to now, and going to go up in size even more. And then it's a gleaming city. There's a bunch of new companies moving in there. They call it the Silicon Hills, and all, there's an amazing amount of stuff happening there. And it's a really fit city. So this is the American Fitness Index that the American College of Sports Medicine puts out. They live a mile that way on the canal. And Austin is the 12th overall healthiest city in the country, with the personal health rank of 7. But the community health rank is 35, and I'll tell you why that isn't so good to begin with. And oh, by the way, here's Indianapolis, all right? So you ain't doing so well. And you ought to talk to those guys on the canal, because they're not doing anything to help the local community. All right, so why Indianapolis is, Austin is actually the 3rd most economically segregated city in the country, after Trenton and Tallahassee. And of the other ones, Houston, Tucson, San Antonio, Ann Arbor, Bridgeport, Los Angeles, 4 of those are in Texas, and 4 of the largest MSAs that have inequities, economic inequities, are in Texas. There's something about Texas, and this is why it happens in Austin. In 1928, there was this city master plan, and this white line, if you can see it here, can you see that? That's East Street, okay? And it is literally a white line. If you were African American or Latino and you wanted to get city services like water and electricity, you had to move east of that white line. So they instituted segregation, and this is what happened. By 1940, the little purple dots are all the black people. So most of them live east of what is now I-35. And it's still that way. So this is last year. So, and you have to look at the scale, et cetera, but essentially most of the whites live to the left of, this is I-35, we used to be East Street, okay? And the blacks live there, and the Latinos live there, and the poor people live there. Okay, so so it may be a healthy city, but only if you look to the left of East Street. If you look to the right of East Street, these people don't have access to health care. They don't have, their life expectancy is 20 years less than the other side of East Street. So that's where we're focusing. If you want to make a community better, you focus on the people who need the help, not the people who are already doing well. And so one way of doing this thing we call a neighborhood health initiative, okay? And this takes after this model, the Community Centered Health Homes model, which was published in 2011 by the Prevention Institute in Oakland, California. And it says that we're going to implement it a little bit differently. In that model, what they say is that you should assess your patients' both medical and social needs and meet them all, and meet the social needs by partnering with community organizations. So if you have a patient who's food insecure or housing insecure, you refer them to an organization that will care for that, the same way that I refer somebody with a TIA to a neurologist or a vascular surgeon. It's a service that we don't necessarily have to provide, but we should have a conduit to people who can provide it. We took it a little bit differently, saying that we want a federally qualified health center to take responsibility for the health and healthiness of everybody who lives in the neighborhood that surrounds it. And we do that by focusing on both the medical and social needs, barriers to health, and again, linking with community partners. And that's why I've got a whole division that deals with that, and a person that's their responsibility in my department. And then also stealing from Kenya. We task shift to the least expensive health provider who can provide a level of care. As Bob said, 95% of the care in Kenya takes place without a physician present, and yet it's high quality care. When I was on the every 15-minute treadmill in primary care, if a patient could be seen in 15 minutes, it didn't take me. Shouldn't take me. Yet my skills were being wasted. My time was wasted. It was horrendously expensive and poor outcomes. And so we can do better with people who cost less. And we should focus on prevention and value-based care. And this thing has 3 components. One is household level assessment. So this is another thing we stole from the AMPATH program. That Bob didn't mention it, but they decided that the only way you're going to break the back of the AIDS epidemic is to get out there and test people, because a stigmatized condition, they weren't coming in and getting tested. So they knocked on the doors of 2 million people and got 98% entry and collection of information, and they've discovered tens of thousands of patients who were unknown HIV positive. They found 10,000 women who were pregnant and didn't know it and got them into care. They found people with hypertension and diabetes, et cetera. So we stole that. with that idea that go house to house in the area surrounding federal qualified health centers, and one where I'll tell you about in a second, and find out what their needs are and then meet them. Don't wait for them to come to you. Then we talked about the community-centered health home model of primary care. And then also support the residents' health promotion initiatives by having something that we stole from Regenstrief, which is your innovation program. So we have a program, a whole center around a call for ideas, and we take those ideas and we have their peers decide which ones are the best, and then we implement them and try to go to scale if they're successful. So again, we're going to focus this initially in an area called Runberg, which is right there, right along I-35 and in the area of economic need. It looks like that from a satellite. It looks like that from a map, and I'll get back to that in a second. Runberg has a total population of just under 50,000, a little more than 15,000 households, 5% unemployment, which sounds great, but it's 2% in the rest of Austin. I mean, it's so booming. There's such a need for workers right now that it's really been a problem. The median age is 25 years, and it's grown 15% in the last 7 years. The average household size is 3. I don't think that's true. I think that's people who actually live there permanently, but there's a lot of coming and going in those households. The median home value is $141,000, where it sounds expensive to you. It's a third of the average value of a home in Austin. The average income is about a quarter of that. Only 20% have a high school degree or higher. 6% have a bachelor's degree, 2% college, and 20% fall below the federal poverty limit in income for their household. So this is the map of Runberg again, and this is where, working with a network of federal qualified health centers, they bought this clinic and said, we want you to use this as a place to create a value-based, community-based model of primary care, because we're really good at the fee-for-service game, and we think it's going away, and we don't know how to practice differently. So they created a laboratory for us to test new models of care, which is really kind of cool. We hired Brandon Alport, came out of his fellowship at Hopkins, sorry. Who's fantastic. I mean, I won't go into it, but he's one of the neatest guys I ever met, and he's now the medical director of this clinic. He's a med-peds physician. And we began with household level assessments, or HOLA, and it's the only cute name I ever came up with, so I want you to appreciate it. And we met with, and again, we actually brought Paula Breitstein to Austin to tell us how to do this, because she was involved in launching of the HCT program in Kenya. And we met with community, with her instructions, we met with community leaders to get buy-in. We met with community residents and essentially barasas to get their trust. We held focus groups of both leaders and residents. We had key informant interviews, and we had them tell us, if we want to assess a healthy neighborhood, what should we ask? How should we approach the households? What should we ask? What should we not ask? Interesting, they said, don't look at my medicine cabinet and don't look at my refrigerator, which are exactly the places we wanted to look. And so we went to, about half these people live in homes that are either buying or renting, okay, and the other half live in housing complexes. And we interviewed 100 households in a trial study, and we found that 91% identified as Latino, 85% of the survey was in Spanish, 79% identified as an immigrant, so this is heavily immigrant community. What you find is that their self-rated health on a 1 to 10 scale is actually pretty good, because it's a fairly young community. The out-of-pocket expenses for how healthcare is paid for is mostly out-of-pocket and various other things, but a lot of it is unpaid for, or I don't know, because I haven't been sick and I haven't gone and seen anybody. We also surveyed another area in South Austin that was mostly African American, and it's mixed, but more African American. I'm not going to go into that, but on the orange bars, you'll notice that as many as 40-50% of these people had been admitted to the hospital in the past year. Think about that. And out of 100 households of the people we interviewed, half of them had been admitted to the hospital, which is about the same amount of people who got in primary care for either usual care or for a problem. That's ridiculous, but it's a nice opportunity to say we should be able to take some of this money for this, where's my thing, for this, and do more of this if we can reduce this. And that's what an integrated care program should do. We also, if you look at this, 24% had trouble paying their rent, 28% had threatened a utility shut-off, 25% were food insecure. This is in Austin. You saw the gleaming city. This is on the other side of I-35, actually straddling I-35. 11% complained of domestic violence in the household. And then, they mostly relied on them, family or friends if they needed money. They didn't really interact much with banks, et cetera. So again, an opportunity to do GC in Austin, which is actually one of our plans. So the next steps in Neighborhood Health Initiative is that we've recruited and we're training 2 community health workers, again, stealing it from Kenya. Go to where the people are. Don't make them come to you if the things you want to deal with are happening outside the walls of your health center. We've strengthened partnerships with community partners so that if we have somebody who has a problem, homebound elder, we've got a relationship with Meals on Wheels. Did you know Meals on Wheels actually fixes leaky roofs? I didn't know this. They'll feed your dog and they'll fill your pill caddy. They see themselves as healthcare providers, and delivering meals is just how they get in your door. Really a cool organization. We work with Central Health, which is their version of Health and Hospital Corporation, to get rid of fee-for-service and use us as a model of how capitation can give them better outcomes at least the same, if not lower costs. The average cost for a primary care visit in one of our FQHCs was $765. That's obscene. We can do better than that. We describe as we do this, we need to describe what happens when we implement this model. And then we want to assess its effects on costs and residents' well-being, both in Runberg and eventually in a control community. That's why we did the other community, the surveys in the community. And I would like to use this instrument, a Santa Monica instrument, but before I get into that, this is something that you all, is Josh here? I didn't see Josh Fester and Near, I know Near's here. This is something that you all published, okay? And what it showed was, in a recent Health Affairs, what it showed was that by focusing, we call them wraparound services, by taking care of the social needs of your patients, you end up lowering costs and reducing hospitalizations, exactly what I showed you on that other graph. This is something that Hopkins keeps coming up here. It's a theme, but they actually took Hopkins is in a pretty poor area of Baltimore, and they took responsibility for the housing complexes that live around there. So not only communicating with their homes, with people released from the hospital, but going out and working in the homes to improve the health and healthiness of those places. And they saw a $113 million reduction in costs to CMS over a period of 5 years. This stuff pays for itself and patients are healthier. We got to stop focusing on healthcare alone and focus it on, that's one small part of health. And I didn't show you another whole set of slides I have, but only 16% of people's health outcomes are affected by the $3 trillion we spend on healthcare every year. 16%. 47% on social and behavioral determinants of health. Sorry, 2/3 on social behavioral determinants of health, and a little small part on the healthiness of the community, the infrastructure. So this is what the city of Santa Monica got a Bloomberg grant a few years ago and developed a well-being index that they administer in a scientific way to people in the community, and then every dollar of the city budget has to affect some measure of this one of the outcomes of the 8 outcomes of this particular measure, and they include, I don't know if you can read those, the personal outlook, community, place and planet, learning, health, and economic opportunity. So health is part of this, but looking at all the other things that affect health. And I would like to actually do this so that we can actually measure if we're having an impact on people's well-being. So what else are we doing? So that's something we're doing in Runberg. What else are we doing in population health? Because that's kind of a little bit too encapsulated. So one is that this is something that Tim Mercer did. Tim, he wrote a grant for he wrote a proposal for a $2.3 million grant from SAMHSA to create a mobile unit that goes out and cares for homeless people, especially people with a combination of mental illness and substance abuse, where they happen to live, which is under bridges or in church basements and stuff like that. And it got funded. So, when you get your first grant funded, it sets really high expectations for subsequent funding. The city of Austin, a thing called HACA, the Housing Authority of the City of Austin, has contacted us and said, we want our 18 complexes to be healthier. We're in the process of renovating one of them right now. We want you to help us put a clinic there, and we want to use that as a focus for health of the entire community. And then we want to focus on the other 17. So it gives us an opportunity, something that you all did. You don't even, most of you don't even know about it because you're too young, but back in 1983, Barton Apartments and Luger Towers and Lionel Arts were 3 housing complexes that we went into to provide healthcare. It was transformational for the people that lived there and the surrounding neighborhoods. Colony Park is an area. Austin has recently voted, the taxpayers voted themselves $750 million of funding to build mixed income and low income housing units. They're building a Colony Park. Colony Park is a 3,000 unit community being put up in an area, a fairly rural area of Travis County, and it's building out a purpose-built community model, which came out of Atlanta. And one of their model communities is just north of 38th Street over here. And if you've never been there, go there. It's awesome what they've done and what they are doing, and the way the community has benefited from that. And it's been sustainable. This Lone Star Circle of Care is the network that bought the clinic where we're implementing our model. They also have a clinic in a rural community called Taylor, Texas. I think Franklin, Indiana. That they were given a building to renovate. They want our design institute to design it as a primary care site. They would also house Meals on Wheels and Head Start. And they want us to implement our health home model there as well. And then we are also launching a primary care clinic for Austin musicians. You know, Austin, there are between 8,000 and 10,000 musicians in the Austin area. The average income is $12,000 a year. Most of them are poor. Most of them are insured by the Affordable Care Act. And yet what they want is a clinic that will cater to them as a group. And an organization that supports them is collaborating with us to build a clinic that will serve them. And then the Austin State Hospital, there are half a dozen state hospitals for the mentally ill around Texas. This one was built more than 100 years ago, and it's a piece of crap. It was falling down, and no one will work there. And so they voted themselves $300 million to replace it. And our chair of psychiatry came in and says, why would you replace this for $300 million for a model of care that was outmoded 50 years ago? So he convinced them to give him $15 million to redesign healthcare for 60 counties of South Texas. That's been done, and now they're voting themselves $285 million to build that model out with a smaller hospital that would be for temporary, not permanent stays, and a bunch of community centers that would link to primary care with more community-based treatment of mental illness. Exactly what ought to be happening and what Indianapolis has been doing for a while with Midtown Mental Health and Eskenazi. And then finally, we're implementing the Amplify model in Puebla, Mexico. We've just, we haven't signed anything yet. We have a verbal agreement with a medical school, a state-run medical school in Puebla, and going to work on developing some of the more rural clinics that are affiliated with them following the AMPATH model. That was just last week that agreement was, and I was going to put the picture of all people sitting around the table. I didn't get it in the presentation. But final thoughts. So population health is a team sport. It takes multiple disciplines. It's not just physicians. We don't have all the answers, and the only answers we have are in that 16%, right? The rest of it, we have to rely on people with others' knowledge and experiences, et cetera. And sometimes even the people who live there. This is an article written by the president last year by the president of the National Academy of Medicine, and what he's saying is population health. Look at it as convergence science, and I'm not going to read this 2-page article, but this is the current state of stuff: is that there are multiple things that can affect the health of a population. Hard sciences, soft sciences, behavioral sciences, healthcare, et cetera. And then where they overlap, we tend to see, can we partner in population health? Convergence science says these disciplines have to take each one of these. I don't care whether you're in engineering school. Engineering actually has a community engineering, community development engineering, and an urban development program. They need to take population health as one of their primary missions. And we're working on making that happen within the University of Texas at Austin environment. But I would encourage you to think the same thing. If you want to be involved with the as Debbie and Lisa and other people are already doing, there are other disciplines within academia that should want to own a piece of that. We shouldn't have to do it in isolation. We lead with care. Again, we're just repeating what's worked in Kenya, and actually Kenya repeated what worked in Indianapolis beginning in 1970 when we developed our primary care general internal medicine program here. But not just primary care, but not just health care, but caring for health. And those are different things. You got to care for health of people who are not knocking on your door. You have to knock on their doors. Focus on both the medical and social barriers to health. It takes a multi-pronged attack where you have to have community partners, and you have to assess the short and long-term outcomes. And sustainability is key. So there's something happening in population health. This is a number of articles where the abstract or the title had the phrase population health in it, published over the last 25 years or so. So this is a new emerging discipline within academic medicine, but within academia and within the country. When I started, I was the 5th Department of Population Health in the country. There are now 18. There are now 3 schools of population health and multiple centers and divisions and institutes of population health. And even the public health schools published a 2-year task force report on population health, saying we're not doing it. Only 25% of the schools have a formal relationship with their local health department. So they're not doing population health. By the way, the person who led that was Bob Dittus, who was Bob's mentor. So it's incestuous. So I don't. You can't read this, but we have an article that about 18 months ago, I convened 8 of the 9 chairs of the existing departments of population health, and we envisioned what the field should look like. And this graphic and these slides are going to be available, and the article is going to be published in May 12th, I think, in JAMA Network Open. But this essentially says this is the kind of super scope of what population health should look like in academia. And you can carve off your little piece of it, but you ought to know what a starting point is, because all these departments are new. Most of them have only a couple been in existence for more than about 5 or 6 years. So it's a discipline that's taking off. I mean, I don't know that there's ever been a talk here about population health, or it's been a phrase, kind of a toss-off thing when talking about something else. This is a focus that I think Regenstrief, and IU is certainly engaged in it, but I think Regenstrief should be getting increasingly engaged and think more about health, and not necessarily less about health care, but more about health in the context with health care should take place within the overall health of the community and the people who live in it. And with that, I thank you. By the way, does anybody know what this is? Yeah, frigate bird, that's right. I know, so we've got like 3 minutes for questions. I don't know, Bob, you want to? Yeah. Bob's got all the answers. I just copy what he does.
Guys, I want to just start by.
You turn on.
There it is. I just want to start by thanking you. Really inspiring talks, both of you. So clearly, you've drawn the connections, and you've pointed out, I think, how well we're positioned to capitalize on a lot of this and leverage a lot of the work that, much of which is started here and continued. So I'm curious, to build what AMPATH has done clearly has involved many years and a lot of trust building and a lot of that kind of activity. And you're relatively early in doing that in Texas with the communities there. What has your experience been so far with that issue of trust, in that, especially in such a historically segregated community?
Well, trust in Austin is actually hard, and it's hard because I showed you that most of the Eastern Crescent, the low-income communities of color east of I-35. On the other side of I-35 is UT. UT is this enormous thing that has 52,000 students, and whenever it needed to build a baseball field, it went over and kicked a bunch of people out of East Austin and moved to the east of I-35. And so the medical school has a terrible reputation in the community. And so we have to overcome that. And one way of doing that, 2 ways of doing that. One is to listen to them. So when I built my department, about 2/3 of the people in there from the community. When we had a summit meeting in February of 2016, and I arrived in January 2016. The second thing is having a community strategy team and listening to what they tell you. The third is having these calls for ideas from the community and saying, tell us what you want to do, and then actually doing those things and making sure that they work and they're visible. So it's been 3 years. We're beginning, I think, to move the needle on that, but it's really difficult. For Mexico, I can't say yet because we're just getting involved. I'll leave it to Bob to say how he had, things he had to do to build trust within the community there. But again, he came in with the Wazungu not having a great reputation with the community.
No, can you hear me? Yes. Yeah, I think you're right, Peter. The entire system is built on individual counterpart relationships with emphasis on relationships. And it takes time to develop relationships, whether it's with your partner or with a Kenyan or somebody in Austin. We said from the very beginning of our program a couple things. First, never promise what you can't deliver, and always deliver on what you promise. It was a very simple phrase, but it's one of the basic concepts that we've tried to hold true for the 30 years of the program. And the second, of course, would be that one's ego is not on trial. And we have to continually remember that and remind ourselves of that.
The other thing that AMCAP did, at its height, it was employing 3,800 people. I don't know how many it is now, but it's a lot. And it was the largest employer in Western Kenya. And yet there were fewer than a dozen North Americans involved, and they were usually involved in supportive roles. They were not out in front. Every program has co-leaders of North America and Kenya, and it's the Kenyans are the ones who are out in front. And building local capacity has really been key. Same thing in Austin, and same thing in hopefully in Mexico as we get started there.
It's why, if I could just make one last comment, it's why I'm so skeptical of so many external solutions, technological solutions, these sorts of things. We all come up with wonderful new inventions and innovations, but the bottom line is it takes time to develop relationships based on trust, based on mutual respect, and there's no shortcut for that, simply no shortcut, and it's a lot of hard work.
Very well said. Maybe time for one more question?
I got one question. Really enjoyed the presentation. I think you hit the nail right on the head. It was very exciting to see the kinds of stuff you're doing in Austin. Can you go back to the slide with all the different disciplines? Because my comment is more of a maybe minor nudge to kind of get you to think about things just a tiny little bit differently. I think the way you described population health was accurate, very satisfying to me. I think you were describing the concept and the theory as well as the goal of population health. I think you were conflating that a little bit with the term population health management, which describes the tactics and the activities that can be done to affect population health. And so there's a little bit, I think, of a distinction that needs to be drawn there, in part because all of these disciplines assist in population health management being successful towards the goal of population health. And if that's helpful, I'm glad to make that contribution. If not, I'd love to debate that.
Yeah, I won't argue that any system has to be managed. I mean, the system we have in this country is perfectly designed to give us what we have now, right? And if you're happy with it, then we're done. If you're not happy with it, then we need a new system, and management has to be part of that. And it's managing at micro levels and managing at middle and upper levels. It's like fractal geometry, right? It has to happen at all levels if it's going to be successful. That's why this is here. That it isn't just science, but it's about management and policy, et cetera. And I put these things in here because there's specific schools at Austin that I'm trying to get their attention with this. So the LBJ school is a very strong policy school, and there's an economics department that has no health economics in it. And business has been a very good partner with us. And so I'm trying to use this to say that it is an all-encompassing thing. Careful with the term population health management, because there actually is an evolving terminology of two different terms of population health. One is total population health, which is the term that Mrs. I'm blanking his name, David. I'm blanking his last name, begins with a B. Anyway, he wrote an article back in 2003 saying that we ought to be focusing on population health. He wrote an article last year that said the term population health. If you look at Epic, they've got population health management tools, right? And for that, population health management is management of cohorts of patients within a healthcare system. That's what population health management is. Managing population health is actually a bigger idea, which happens both inside and outside of health systems, and they need different and collaborating and interactive interfacing systems to make it work, because much of the money that's going to drive population health is being wasted within health systems now. So if we're going to pay for this, it's not going to be by taxing ourselves more. It's going to be by moving some of the funding, paying for health care that is not improving health, and move it into systems to get upstream from sick care into caring for people's health. That's going to be hard because that money is currently going to people's pockets and they don't want to give it up. So this is going to transformation going to take place over years. And you're right, it has to be that transformation, and the steady state afterwards is going to require a lot of management.
I think you're talking about David Nash.
No.
And the second slide you showed with all the different definitions of population health, I think there are population health management applications in each of those definitions. So thank you.
Okay. I won't argue with that. It's a field that's undergoing rapid evolution, so is the terminology.
Well, thank you all again. Another round of